Right, I think we'll make a start. I can see lots of faces, a few people still coming in. Thank you everybody for attending. So just to check you're all in the right place, this is the fourth session in our RIC, our Reducing Inequalities in Communities Learning Week. And you should be at the How Community Engagement Can Improve Health Literacy. So just check that to start with. We'll make a start in a minute. We've just got a couple of housekeeping announcements. I'll introduce myself. Actually, that's probably be a better place to start, wouldn't it? So I'm your host for today. We've got three presentations. I'm Duncan Cooper. I'm the Associate Director of the Reducing Inequalities Alliance. So we're the team that oversee the RIC programme and are bringing this week to you. So just a bit of housekeeping to start. If you could pop your name and your organisation in the chat function, that'd really help just for a bit of our record keeping. Put yourself on mute unless you're asking questions or you're speaking. So we can't hear people coming to the door and putting your washing out and things like that. And then we are recording this session. So if you don't want to be filmed, turn your camera off because we're going to record it as well and put that out there. And also, if you want to promote it via social media, feel free to do so. If you want to tweet it, we're using the hashtag Reducing Inequalities BDC. So if you use that hashtag as well. So that's the housekeeping. We've got three sessions. We've got three presentations today. We've got Abby and Caroline that are going to be talking about genetics and targeting whole community and co-design. We've got Claire, who's going to be talking about future focus, which is around at-risk mental health states and psychosis. And then we've got physical activity in the BEAT project, and Andrew Mountain's going to talk about that. Overall, we wanted this session to be around how different sorts of community engagement can really improve health literacy and how specifically targeted community engagement can do that depending on the particular health issue that you're dealing with or the particular cohort that you're trying to engage with. So we've got three quite different projects there. And although some of you might have been at some of the sessions last week, just to give you a little bit of background to RIC, because you might not all be familiar with it. So we began the RIC programme in 2019. Then as now, we have big health inequalities in Bradford districts. We see about a 20-year difference in healthy life expectancy caused by all sorts of different types of things. And we had some additional money from the government to focus on reducing inequalities in central Bradford. So that was the old Bradford CCG, so PCNs 4, 5 and 6, if you're familiar with primary care networks, but it's the central core of Bradford. So we had some additional money and we set up a life course programme, which was called Reducing Inequalities in Communities, with about 20 different interventions and projects that all got going across the life course. So we've had a lot of work in terms of adult health literacy, but also in the mental health world, in the maternity world, and also end-of-life care as well. So there's all sorts of different projects that have been feeding back about. Three of the really good ones that have made it through COVID as well. A lot of the services really had to sort of change the way that they engaged with communities, engaged with service users during COVID as well. So you'll probably hear a little bit about that today. So that's the background to RIC. Sophie's going to be putting bits of information in the chat on our overall RIC report that will be coming out soon, and also a video as well, which really covers the background. And we've got plenty of stuff on the website as well. So if you have a look in the chat, you'll see various links going in there. We've got an hour together, so I've just asked all the three speakers to try and keep to time, because we've been getting a lot of questions in these sessions as well. So it'd be really good to have enough time for some questions and a bit of discussion and chat at the end. So if you could keep to time, that's great. I think Sophie's going to be driving the slides for you all, so hopefully that will work. And then we've got a video as well from the BEAT project that we're going to play at the end of Andrew's presentation, hopefully. So that's it. So put your questions in the chat if you want, and we'll make a note of that and hopefully have time to come back to them. But we'll also have a bit of time at the end, hopefully, for you to put your hands up and ask questions in person. Okay. So I think what we're going to do, I think we've got Caroline and Abby first talking about genetics. Is that right, Sophie? And I think you're going to start off by sharing the slides. So Abby and Caroline, over to you.
Thanks, Duncan.
Thank you.
Hi, everyone. So my name's Abby Wild. I'm the programme manager for the Best 1001 Days programme. We've got quite a number of slides, but we are going to whiz through these really quickly. So conscious that we've only got 10 to 15 minutes, but just wanted to give you a little bit of context So this is the Best 1001 Days programme, and the Every Baby Matters work stream sits within that. So we're pillar one for the Healthy Children and Families priority area, and we work collaboratively across all sectors and organisations to achieve our vision, which is working together to improve experiences and outcomes for pregnancy, birth and beyond across Bradford District and Craven. Next slide, please. So this organogram just shows the structure of the Best 1001 Days programme, and I've highlighted where the genetic work sits, and that's a subgroup of the Every Baby Matters work stream. Next slide, please. And Every Baby Matters was set up in response to recommendations from the Infant Mortality Commission report, and that was to address the high rates of infant mortality in Bradford. Next slide, please. So 4 years ago, Every Baby Matters came under the umbrella of the Best 1001 Days, and that was really to strengthen the work with a partnership approach. And the vision of the Every Baby Matters work stream is to ensure that every woman is fit for pregnancy and every baby has the best start to life, with a focus on reducing health inequalities. Next slide, please. Through the programme, we also act on recommendations from the LMNS, which are benchmarked against each of our Every Baby Matters ambitions. So you can see there that rare genetic disorders sits beneath the LMNS recommendations as well. Next slide. So the infant mortality rate in Bradford District remains above both the regional average and the England average. And the gap between Bradford and the England average has widened to 2.5 deaths per 1,000 live births. Bradford District has the 7th highest infant mortality rate in England, and it has the highest infant mortality rate within the Yorkshire and Humber region. Next slide, please. So we can see from this chart that we're an outlier compared to our regional counterparts, which is even more concerning when we know that the regional infant mortality rate is higher than the England average. Next slide. The number of deaths reviewed per year does not vary greatly, with just one peak noticeable in 2011 to 12. And the breakdown by cause of death has seen a similar trend since 2008 to 2009, with category 7 and 8 deaths accounting for over 2/3 of all deaths each year. Next slide, please. So here you can see that the dark blue is Bradford at the top, grey is our region, and the red is the England average. Next slide, please. Through the programme, we also act on recommendations from CDOP, so that's the Child Death Overview Panel, which explores every death of a child in the district and looks at modifiable factors. So you can see here that the highest number of deaths is attributed to category 7. That's chromosomal, genetic and congenital anomalies. Next slide, please. And this slide shows the actual number of individual children who sadly lost their lives in the year 22 to 23. Every single life lost is a tragedy, and every single loss has a family, a community and a workforce who is devastated by such a loss. I'm going to hand you over to Carolyn now for the next set of slides.
Hi, so I'm Caroline Sadler, a public health specialist from Children and Young People's team in Bradford Council. So we know from evidence that it suggests that consanguineous marriage is associated with higher rates of congenital anomalies, in particular autosomal recessive genetic disorders. And these are conditions that occur when a child inherits the same pathogenic gene variant from both parents who are healthy carriers. And the risk of a birth disorder of 5 to 6 per 100 births compared to 2 to 3 per 100 births in the general population. So children with a congenital anomaly in Bradford District have a 50% higher chance of use of hospital services, and there are currently over 170 autosomal recessive disorders described in the Bradford population. Next slide, please. So this table shows you the baseline data when we're applying for the RIC funding, and that was showing that 36.9% in Bradford at BTHFT are from Pakistani ethnic groups, and from Airedale 15.4% of those from a Pakistani origin. Next slide, please. So the key objectives were informed by the multi-agency steering group and the West Yorkshire and Harrogate Health and Care Partnership local maternity systems at the time. And there are 4 main drivers to responding to the increased genetic risk. which are these four here. Slide, please. So just to give you a quick overview, obviously the project was put out to tender. We invited organisations to bid, and Women's Zone were successful in securing this project. We recruited a project coordinator who has a background in teaching secondary school science and is also a degree in genetics. And we also commissioned a consultant who is an expert in genetics. Then use the logic model then to inform the actions and the inputs. So what we will do, the outputs, how we will know we have done it, and how we will know we have made a difference. And then we use those then to influence our KPIs to measure if we've reduced the health inequalities. Initially, we were measuring mainly quantitative, and what we realised is that actually we needed more around just bums on seats at training events. We wanted, with support from the RIC evaluation team, to also capture some of that narrative, to tell the story of how the project and the genetics in communities is supporting and making a difference to families. So we are also collecting case studies. Next slide, please. So genetics in communities had three components to their work: raising genetic literacy in communities, looking at outreach and events, supporting families that are at high risk of recessive genetic disorders, and to train and support our health professionals and providing training for them. Can go on to the next slide, please. So what you will notice from here, and we just have an amendment actually, we've got 436 service users and 283 health professionals. It's just we've got them the wrong way around on this slide, so we will send out a new slide for you. But what we'd like to say is that we've actually run an amazing 36 sessions for health professionals through this project. And what we'll find is that if everybody had turned up, and we know we've got a lot of challenges to our health professionals attending training, but if everybody had have turned up, we would have trained well over 430 health professionals. So we still have a lot of work to do, but we know that there's an appetite out there for it. It's just the challenges that we need to overcome, which we'll talk about how we've managed to do that. Next slide, please. So we've also linked in with our NHS England funding to ensure that we are working across our place, to ensure that we're working across our community centres, schools, various forums, and we're also looking at how we can embed the various programmes and working in collaboration with the RIC project, to link in with the preconception service, to link in with Bevan House, and also to look at how we can increase our response to empower families to make an informed reproductive choice. Next slide, please. So this slide is simplified from the World Health Organization. In essence, it shows the coordinated approach that's required to reach all sectors who are working closely to support families as part of the family-centred approach. And on the next slide, I've made that simpler for you. So some of you may have seen this before. So we ultimately have the family in the centre. We know that the family may need support from the Every Baby Matters steering group. We know that the LMNS recommendations are also influencing how we can approach this as a project. We know that we're linking in with the preconception service to ensure that the families can reach that information and to make that informed reproductive choice. Maternity circles are now up and running, thanks to the great work that's happening. We know that genetics in communities offer training both for health professionals and for families and communities. They also offer support, and we also have then links through the NHS England funding with a genomic associate at the Regional Genetics Service. We're now recruiting a close relative marriage midwife and also personalised care support worker. And we have a genetics project support administrator. And this is just to show you really on how much it's all taking for us to actually do the work that we're doing and how we can show you how we've done that as co-production. Next slide, please.
So this case study just really demonstrates how important the work of this programme has been. Aisha was a carrier of a rare genetic disorder, and her husband was also a carrier. Their first child was born with a serious condition that required a lot of support. And sadly, Aisha and her family didn't receive the support that they should have received following the birth of this child. Next slide, please. For several years later, Aisha had another child who was also affected by this condition. And this led to a breakdown in the marriage. This was a really sad case where Aisha was actually estranged from her family and her husband's family, and blamed for the conditions that her children had, owing to a lack of understanding of genetics and how this affected her children. Now, if the services had been in place, lives could have been completely changed, and lives potentially could have been saved if Aisha and her partner had had the information right from the outset or between the two pregnancies. So it just shows how important this work is. Next slide, please.
So the Reducing Inequalities in Communities work at the Genetics in Communities have worked tirelessly over the last couple of years, and as Duncan mentioned, obviously we had 5 years originally as part of this project, and that was reduced down to 3 because of COVID. And then we had a slow start really on working out how we could actually reach the communities and how we could reach the families and the health professionals, up against all the barriers that were out there at the time of people not really going out to events and what have you. So the Genetics Communities and Mazish and Amradar have worked tirelessly in producing and developing different resources, and worked closely with families to help them to build that up. And what they found out very early on in the project is that rather than just talking about genetics, they realised that actually the literacy was at such a level where actually the community needed to know more about actually the body systems and how the body systems worked before they even talked about cells and how and where genes sat and how that all worked. So that was one of the key things that they've now produced. They also produced a document that families, once they'd accessed this training that ran over a 6-week period initially, could also take away with them different resources that they could take to their families, so they could go and have a conversation with their families. So this was then about how one person could go out and reach maybe 5-6 other members of the family to discuss with them about what they'd learnt. So this was then taking away stigmas. It was taking away people feeling judged, people to be able to go back and then have a conversation about the conversation they'd had with their family. So it was just about building up slowly but surely all the resources and how the genetic literacy was going to be developed to be able to reach more families and more communities and help them understand ultimately how they could have a reproductive choice, and how they could maybe have discussions with their families before maybe marrying certain cousins, and maybe looking at what the risks might be so that they could have some genetic testing. They could reach then different services, and in that case then they could then look at about which other family member that they may want to marry once they knew what their genetic risk was. Next slide, please. What Mazish also has a skill of doing, and has worked really closely with the communities and the families, is also to build up to how they can best support families to understand genetics. So here you can see as learning the children how to extract DNA from strawberries. This is something that she did when she was working with the Bradford Media Museum, so that she could engage the children. And while the children were learning, families were also there, so then they could then also have a conversation afterwards about what it all means around genetics, how it all works, and how they can then raise their genetic literacy, certainly for those that are high risk and those that have identified that their families do have a condition within the families. Next slide, please. Part of the RIC project has also purchased different resources for them, so the human body, helix, different things to show people around what a cell is, what's inside a cell, and how that all works. What Amra also has the skill of is having a multi-language, so she can deliver sessions in Urdu, and she's worked really, really closely with families and communities to how best deliver that, how best to deliver the sessions, how it's received, and what their takeaway from that will be. And they've also then built the website at Genetics in Communities as Women's Zone. So can you just put the next slide up, please, Sophie? Thank you. So you can go onto Women's Zone and you can go into Genetics in Communities and have a look at their website. And this has been built together with communities to ensure that it's targeting at the right level, that people are really understanding and getting the best out of the information that they're needing to receive. And Amra and Mazish have also been out to a secondary school and worked with secondary school children at maybe 15, 16, speaking to them about family trees, making sure that everybody could maybe produce a family tree together. From that, then they would talk about genetics and how genetics can then be affect families. Going on to then talking then about different careers then within genetics. So each different event they have personalised and made a bespoke events depending on who the communities were they were speaking to, who that they've been hoping to achieve the outcomes from, and to ensure that it's been targeted at the right communities at the right level. But this has just been really at the heart of where Women's Zone is situated, and how we can reach those families that are at highest risk, and how we can make sure that they've got that information to go and have an informed reproductive choice. Next slide, please. And those are just the other sections that you can see when you click onto the web page if anybody wants to have a look. We've got one around professionals, one for everybody, and one supporting families by a genetic disorder. Thank you. Okay, I think we've kept to time, hopefully. Thanks, Duncan.
Thanks very much. Yeah, I was just about to say, are we near the end? That was fantastic. It's a huge amount of information in there. So hold your questions for now. I think we'll go to the other two presenters just to make sure that we've got enough time. But that was a really good from start to finish presentation. Thanks for that about this, and it's really great to hear that personally as well, because I remember being involved in writing the initial bids to try and get that off the ground 5 years ago. So it's brilliant that we're here 5 years later and it's had all those results. Okay, so I think we'll move to future focus next. I can see Claire, so I hope you're ready, Claire, and Sophie, if we just go straight into the slides. Thanks.
Hi. Hi everyone. Thanks. So I think my presentation is probably going to be a bit more succinct, a bit shorter, but not as impressive. That was a really good presentation. So I'm here to talk about future focus. So my name's Claire McMaster. I'm the senior psychological therapist. I inherited this project, I think, after the first year. So I've been working on it since probably about 2020, I think it was 2019. So yeah, it's been something that I've been working with for quite a while. So I'm really excited to talk to you about what we've been doing within the communities of Bradford, and how we've kind of worked with the RIC funding to kind of make a difference. So next slide, please. So just to give you a bit of an idea of who we are and where we sit. So we sit within the Early Intervention in Psychosis team, which is an existing BDCT service that supports people with the first episode of psychosis. So this project was kind of born on the back of obviously inequalities within Bradford, but also a national push to provide what we call at-risk mental state provision within all early intervention in psychosis units up and down the country. So we already had a small provision to work with people who are assessed as being at risk of developing psychosis, but the RIC funding allowed us to really invest in that team and really broaden our scope, but really start to think about reducing those inequalities and recognise the inequalities that exist in Bradford around psychosis in particular. Just to kind of give it a brief kind of outline around psychosis. So the at-risk mental state is a collection of symptoms and experiences in its own right. And what we see with the research is that if people are particularly vulnerable, and if people are left unsupported and with additional stressors, they can progress onto a first episode of psychosis. So the early intervention team already aims to provide early intervention, obviously, but the future focus team and at-risk mental state team look at early intervention. So really reducing the risk of developing that first episode, with the aim of reducing need for acute services and ongoing secondary care support in future. So we offer a slightly different provision to our early intervention team. So we support people aged 14 to 35, and we work with a lot of diagnostic uncertainty. So our remit is a higher risk of developing symptoms of psychosis, characterized by higher vulnerabilities in terms of trauma, but also kind of lower levels in terms of symptoms of seeing things that other people can't, hearing things that other people may not, and being withdrawn from their family or their everyday life. So we offer brief intervention and psychological therapy for over 2 years. We are a psychologically informed service. We don't have any medical provision, and we work very much to a biopsychosocial spiritual model. So we do work quite closely with our early intervention team. Like I said, we are embedded in that service. So if we need specialist input from psychiatrists or medics, or if we feel like people may be transitioning to a first episode of psychosis, it's literally an email away to make sure that people are in the right kind of service and get the treatment that best suits their needs. So I hope that gives a little bit of an outline of who we are and where we sit within the broader structure. So next slide, please. Okay. So when we talk about at risk, we can think about everyone being at risk of developing kind of mental health illness or even a psychotic experience in their life. So we very much come at it from a stress vulnerability model, which is any human brain put under a specific amount of stress would kind of be vulnerable to developing kind of mental health illness, which includes things like hallucinations, delusionary thinking patterns, erratic behavior. So this isn't something that's seen as disordered. I guess from our perspective, we see it very much in a trauma-informed model. If we really narrow it down a little bit more in terms of what we mean by an at-risk mental state, we think about vulnerabilities in terms of age, trauma, ethnicity, minorities, poverty, instability, and young males. So these are the kind of big hitters, I suppose, in terms of what would make anyone with a genetic vulnerability or a family vulnerability to psychosis kind of higher level risk to developing the experiences. So if we think about Bradford, can we just click along, please? Oh, actually, keep clicking. I think I put too many. Yeah, thank you. Okay, so if we think about putting that into context, so Bradford is the youngest city in Europe. So we know we have the highest number of young people across the board. So that already puts us in a higher risk in terms of our population. Bradford is ranked the 5th most income deprived local authority in the UK, with 24% of children living below the poverty line. So we can think about what experiences that would provide the young people that are living in our poorest areas. So that's going to really contribute to childhood experiences of trauma. So adverse childhood experiences being ACEs that contribute to that higher level of risk. We think about instability, we think about education and access to resources. These are all going to impact on mental health as they get into that higher risk stage of 14 to 35. And we know that Black, Asian, ethnic minority communities are at a higher risk of developing psychosis. And then we put that in the context of Bradford. We know that 39% of the population are classed as Black, Asian, ethnic minority communities. So it makes sense to really think about having an at-risk mental state provision solidly within the Bradford area. If we click along, please. So just to delve a little bit more into those inequalities and to think about how that specifically relates to psychosis and at-risk mental states. So we know that Black men are more likely to have experienced a psychotic disorder, and this is kind of in 2016 to 2021. And we know that Black people are 4 times more likely to be detained under the Mental Health Act than white people in Bradford. So in Bradford, Black African and Black Caribbean individuals are a majority within a minority in acute care hospitals. So we know there's roughly around 2% of Black African and Black Caribbean individuals within Bradford, and there are overrepresentation of these ethnicities within our acute hospitals. So they're more likely to be detained under the Mental Health Act and taken into hospital and restrained, and under what we call a cluster 10, so being classified as having a psychotic illness, closely followed by Asian males. So Bradford has a higher incident rate of psychosis than the rest of the UK, where we're looking at 50 in 100,000 in Bradford compared to 25 per 100,000. So we sit within the big hitters, I guess, of London and Manchester and Birmingham, and we think about our size comparative to those cities. It just doesn't really make sense in terms of those numbers. So our incident rates are quite large. When we think about the RIC funding and those inequalities, we saw that EI was not representative of the communities of Bradford within our cluster teams. And what we know is actually when we see people admitted into hospital into acute wards, we know that we've missed that opportunity to really support people early on in their journey. So instead of seeing people in acute wards, we really should be seeing people very early on in our early intervention team. So there was definitely questions to be held there around how do we help the male population of Bradford? How do we help Black men in particular? How do we support Asian males, Pakistani males to come to our service, and for us to make it safe and make it accessible for people to come to our service in the fall, rather than wait and have these symptoms kind of progress into something a lot more sinister for them. Next slide, please. So our aims to reduce inequalities was to really start to think about what those barriers might be and have a think about what our responsibility were as statutory services to really kind of reduce those barriers. So we thought about tapping into existing VCS services, voluntary sector services in Bradford that actually did some great work with the communities and already had those relationships and those links made. So we worked with Sharing Voices and Inspired Neighbourhoods to really start to listen to the communities and really start to embed our staff and our services in existing safe spaces. So we think about making more of an effort and being out in the community and taking our time with these relationships that we need to form. What we know is that people are more likely to work within faith communities and access support from imams or priests rather than come to a mental health service. Particularly when we think about some of the experiences that sit within the at-risk mental state framework. There's a lot there around hearing voices or hearing things that other people can't hear. There's things around seeing things that other people can't, or having strange or unusual beliefs. When talking with the communities, what we realize is that actually it's a spiritual explanation that people tend to go to first rather than a mental health explanation. For that reason, people are more likely to go to mosques and imams and seek help from the community in the first instance. Now, whether this can actually offer a lot of support for some individuals, what we do see is that actually it does sometimes delay access to mental health services. And what we know with at-risk mental states and psychosis is that actually the quicker the better. Research has shown within the first 12 months of experiencing symptoms is the best time to access support for an at-risk mental state, and the first 3 years for a full psychotic episode. So time really is of the essence. So what we also found as something that delayed that kind of support is working with families and accessing support from family members, or actually shielding that individual from kind of other parts of the community or other services due to kind of stigma or due to shame or due to kind of lack of awareness of where to go. So working with the families of those already in service and accessing, or like say, existing services through VCS organisations, we were able to do a lot of awareness sessions and a lot of drop-ins in the local faith centres and local mosques to really start to talk to families about mental health and the symptoms, and think about answering questions and breaking down those barriers to engagement. So thinking about one thing that had always been a bit of a challenge, I suppose, is sometimes what we were commissioned to offer didn't necessarily match what we were seeing within the communities. So we're doing all of this work around engagement and all this work around sitting within community services and sitting within mosques and churches. But actually, when people came to our service, we were offering a very westernized, Eurocentric, structured way of looking at mental health, which didn't always feel all that kind of genuine, I suppose, in terms of all the work that we'd been doing around spirituality and mental health. And then for people to come in and not actually have their needs met in a culturally appropriate way was something that we'd put a lot of well, that actually kind of hit us kind of, well, when we started to see the referrals after lockdown. So we've had a lot of conversations with our senior management team and thinking about offering a different way of kind of, well, offering mental health support. So offering brief intervention and a structured brief intervention that works very much with different members of the community and the VCS providers, but also accesses support and information from imams and priests and faith leaders. So instead of everyone has to have psychological therapy, i.e. structured CBT, it was a case of actually people get what they need and people get what's important to them. And actually people, it is a very person-centered and very individualized way of offering treatment, still within the same framework of, you know, a 2-year service, and still within the same principles of a stress vulnerability model, kind of formulation, and kind of change methods, but very much tailored to the individual. So we do have a kind of number of people within our service who very much, you know, buy into CBT, but we have a lot of people who need a lot of family work, a very unstructured way of working, and a very tailored, culturally adapted way of working. And I suppose that kind of links a little bit onto that second kind of the last target there, within building trust within the communities and not just target driven. So I must admit our targets did take a bit of a hit. So in terms of our waiting list, it looks like we do have a lot of people waiting for therapy, but actually we do have a lot of people engaging with our recovery coordinators, our care coordinators, and our community development workers to really understand their difficulties and change their stresses in a different way. So it does mean that we add quite a substantive narrative onto our target reports as well to just kind of explain this. Next slide, please. So what we have...
Sorry, just before you start, could you just finish up in the next couple of minutes? That'd be great, thanks.
Oh, sorry, about
just for time, yeah.
Sorry, yes.
We've got another speaker.
So yes, so basically this slide, it just shows the changes that we've had in our access in terms of ethnicities. So we've seen a significant increase in our Pakistani community. So you can see that bottom yellow line there is our 2024 numbers compared to our 2020 numbers, which is the blue at the bottom. Similarly for our Black Caribbean and Black British individuals as well, we've seen that increase there. So we're really starting to see our community work. Next slide, please. So I guess what made a difference is having a presence in the community. So actually, can you just click along again? I think I put some animations in here, which is, yeah. So having a presence in the communities and being consistent. So having, having those regular spaces that people start to learn to trust. It's not something that worked overall straight away. Seeing the whole family approach, not just the individual, was really helpful in really creating that trusting environment, but also making it easier for people and making the family a conduit to accessing services rather than a bit of a barrier. And the mosque and the church drop-ins seem to have been the things that really have made the big hitter. So some of the quotes down there from an imam from the Islam Bradford Centre and the manager from the Al Mustafa Centre, where our community development worker Zahid has been working very hard to kind of have a presence in that community. And it seems like it's actually starting to reduce some of that stigma and taboo. Next slide, please. And I was asked to give 3 key points around community work, and if anyone was embarking on this themselves. I would say it takes time, patience, and consistency. If you want to build trust, you've got to be there no matter what. And I guess it takes a lot of time to build trust and kind of think about reshaping the way people might view statutory services. It also takes a bit of flexibility around your targets. Make sure you have a long-term plan or set expectations. So we think about our presence in the community potentially needing some thought after 2025. So that's something that we're going to have to do. And listen and collaborate. So it doesn't make sense to go in there and dictate what communities will want. So always be prepared to have an open mind and change what you originally thought might work. So sorry, thank you.
That's great. Thanks very much, Claire. And again, it's another really good example, isn't it, of how sort of VCS organisations are not only delivering but enabling other services as well, and being that sort of conduit into communities. So that was great. Thanks very much for that. What we'll do now is we'll move on to the next presentation from Andrew, which is about BEEP. And you'll have to tell me what BEEP stands for, Andrew. I'm afraid I've forgotten. I know it's to do with physical activity referral and all that. So that exercise referral, that's great. So you've got about 15 minutes. That's if that'd be okay. And then we'll have about 5 minutes at the end, hopefully for a few questions.
Yeah, that's fine. Yeah, I'll go through BEEP and everything like that. But yeah, my name's Andrew. I am the exercise referral lead for the BEEP RICS project. A little bit of background on BEEP. It stands for Bradford Encouraging Exercise in People. It's been going since 1995 as an exercise referral service supporting patients with a BMI of 25 or above. They have a long-term health condition or mental health condition or higher risk factors of developing cardiovascular disease. The sort of aim of the project is to support people to become more active more often with exercising within the community in a little bit of a nutshell. Can you go to slide 2, please, Sophie? Thank you. So RIC funding RIC programme has sort of funded an enhancement of the existing BEEP service, but more of a focus on the needs of patients sort of in central Bradford. As mentioned before, we aim to support patients with long-term health conditions become more active, with hopefully an overall improvement to general health and better help manage health conditions in the long run. We offer a 52-week follow-up support service with regular engagement points throughout this period, and we sort of pride ourselves on offering bespoke exercise plans designed by qualified exercise professionals within community-based exercise to make it safe and appropriate for users coming through the service. We've sort of been asked today to go on to a little bit of an overview of our engagement with patients over our sort of follow-up over the 52-week period that patients are with us. So if we can just go to slide 3, please, Sophie. So yeah, we have a mixture of face-to-face engagement points and telephone contact points as well. And with the RIC funding, we have been able to add an extra contact point in at week 8. So week 1 would consist of a health screening process, a health and wellbeing questionnaire, take into account what a patient may be interested in physical activity wise or what they've enjoyed previously to try sort of work that into their exercise plan. And following that, we, as mentioned before, we put a tailored and bespoke exercise plan together related to their reasons of referral, be it a long-term health condition, weight management, rehabilitation from certain services. And then we also look at taking blood pressure, weight and body fat and muscle percentage at that appointment as well. The week 4, 8, 26 and 52 are all done via the telephone, and it gives us the chance to either give a patient a pat on the back and a well done if they've managed to get going, or break down any, sort of discuss and break down any barriers, which I'll come on to a bit more detail in a moment. And then the week 12 review would be a follow-up of sort of what we're taking at week 1, a chance for the patient to offer any feedback, that any good points or any things that we can work on as a service, and a general sort of touching point really, just to re-engage with them and see how things are going. But yeah, the week 8 contact point, looking at using the exercise referral toolkit, adding that one in the first 12 weeks of a patient becoming more physically active is sort of the key area that we want to work on, sort of long-term behavioural change and long-term physical activity sort of participation. With the week 8 added in, we've managed to sort of looking at previous data. So BEEP RIC started in mid-2021. So since adding the week 8 engagement follow-up point, we've been able to have a 10% increase in clients who have reported being active at the week 12 contact point compared to before this, and it's an overall sort of 17% reported by patients an increase in their overall health and well-being since becoming more active at the week 12 contact point. With this in mind, we do always go out into the community. We've been doing a lot of work with the Goodwarers for health check events, doing some blood pressure checks and the scales as well, and trying to promote physical activity. We've worked with the Dominican Association, and we had quite a big health event up at the BRI for health checks and sort of promoting BEEP as a service in the wider Living Well projects as well. Alongside this, we've trialled a few different methods of engaging with the community, but looking at a cohort of patients from different long-term health conditions. We work with Thornbury, sending out a text message to a cohort of diabetic patients to send the BEEP animation out there on the text message to give them an overview of what BEEP may be and becoming more active and the benefits, as well as advising them of the referral, that it is the here in Bradford and is something they may be able to take part in. But the main bit we can sort of offer is the heavily discounted exercise provision and being referred on to qualified exercise professionals within the community, be that cancer prehab, cardiac rehab, or exercise referral for sort of general long-term health conditions within that as well. A couple of bit of feedback that we've had off patients, and it sort of incorporates the engagement points. So we've got a male who was 45. I feel fantastic since losing weight and becoming more active. My follow-up appointments and phone calls have really helped me achieve my weight loss and physical activity participation. And then we have a female at 65 years old. I'm really impressed with the service, especially the support and motivation, and also they'd managed to lose 5% at their week, 5% weight loss at their week 12 engagement point. But yeah, as mentioned, that first 12 week is the sort of key area to supporting someone become more active. And as mentioned before, with the barriers, it could be that they've had a loss of confidence, they didn't really feel comfortable making that next steps into the community-based setting, be that a gym or a swimming pool. It may be something they haven't done for a number of years. So just having that contact point there allows a patient to express any concerns, or we can maybe point them in the right direction of if we can go meet them, or different sort of ways and means of supporting them, maybe to go into a centre, or the next steps of sort of a phone call of maybe booking into a walking group or whatever their referral option was, moving into that. But that's a little bit of an overview on sort of our engagement points and adding the week 8 one in. And if we can go to slide 3 or 4, put next one, Sophie, please. Oh, sorry, can we go back one? Apologies. And yeah, just same as the ones before, sort of key points from our BEEP RIC project journey. We've developed different referral pathways, so be that for the RIC practices, PCM 4, 5 and 6, to be able to do an e-referral via System 1, social prescribers to be able to refer them with clinician sign-off, hopefully making it a wider spectrum of people, referrers being able to come through. And we've also trialled self-referral with these practices as well within PCM 4, 5 and 6, hopefully to take a little bit of a strain off the referrers, and the patient can sort of activate their referral by contacting the admin. As sort of just discussed, regular contact points in those initial stages of a client becoming more physically active is up to that 12-week marker. The more contact I think we have with them, hope for our better outcomes, and they feel better supported coming through the service. And I think, as mentioned earlier, a bit that we pride ourselves on is ensuring that when a patient is referred into community-based exercise, that they see the relevant qualified instructor for their referred conditions. If they've got any questions or have any symptoms while exercising, the instructors who are qualified in those areas will be best placed to support them and advise them. And the last bit would just to leave you with a short video of a previous client patient that has come through, which is called Julie's story, which is quite overwhelming of how well Julie's sort of done and the information that she mentions in the video. It's really nice to see coming through the service. But yeah, thank you very much for your time and listening.
Thanks very much, Andrew. And I think Sophie's going to try and play the video now. See if this works.
My name's Julie, I'm from Bradford and this is my story. Being healthier, spending time with my family. I've got 2 grandchildren and 1 on the way, so it's really important that I look after myself. I want to be around to see these children grow up. I've been diagnosed with diabetes and COPD. I also had really bad pains in my legs. The pains in my legs were so bad that I was begging for painkillers, saying I can't cope with this pain any longer. The doctor sent me away and told me to do some small exercises, which really did help. I needed to change my life for the better, so I decided that I'd join Slimming World, and after a few weeks I returned back to the doctors for my checkup, and doctors suggested that I could possibly go for BEEP.
BEEP, which stands for Bradford Encouraging Exercising People, is an exercise referral service that aims to get the inactive active. If you have a long-term health condition or a BMI above 25, you may meet the criteria. Julie's story is a perfect example of the BEEP process. After consultation with her GP, they've both decided that engaging in community-based exercise was the safest and most appropriate option for her to take. If you feel you'd benefit from a referral to BEEP, either contact your GP or contact the BEEP team.
After about 4 or 5 weeks, I started feeling a lot better in myself. So I then started going to the gym twice a week and also going swimming twice a week and also going to aqua aerobics. And it's made a huge difference to my life. I'm now healthier, I sleep better, I've made lots of new friends and I'm absolutely loving it. I'm no longer diabetic, I was on the diabetic borderline. I'm no longer in the diabetic range at all. I also had COPD, which has now gone down by 6 years, which is amazing. And the pains in my legs have almost gone completely. I'm enjoying the swimming so much that I now take my grandchildren, both of them come along with me, which is really nice. And I've also converted my granddaughter to come and join the gym with me. And my daughter and son-in-law are joining soon. It's never too late to start healthy eating and exercise. I started at 57, I've lost just over 3 stone. I'm just at the beginning of my journey and I'm having so much fun along the way.
Thanks, Sophie, and thanks, Andrew, for sharing that. It's great to see like whole family getting involved as well at the end of that, which is what we want it to grow and expand. Right, we've only got a few minutes left, and there were a few questions that came in, so we're just going to go back to those. The first one, Claire, was for you from Carlton, and it was about whether there'd been any work locally on the effects of cannabis on psychosis in Bradford, or whether there's any particular impact there that you know of.
Well, there's definitely a relationship between a number of drugs and substances and development of psychosis. We haven't done specific research ourselves, but I'm aware there's quite a range of literature out there. One thing that we are embarking on is work with VCSs who do supply support for substance misuse. So recognising that when we think about trauma-informed practice and trauma-informed care and all of the other vulnerabilities that I mentioned, that there are a lot of substance misuse kind of issues that come along with that. And I think traditionally mental health services have very much kind of said, oh, we'll sort out the substances first and then we'll sort out the mental health. I find that actually we're moving in a better direction when we're really looking at the relationship between the two, which is undeniable. The one thing that we think about is psychotic symptoms in the context of drug use that may have been triggered by an episode of substance misuse, but actually exists in its own right. I think when we see drug-dependent psychotic symptoms, so whenever you take the substance, that's when you experience things, you have a period of abstinence and it disappears, that's something that we wouldn't necessarily work with. So it's a complex kind of relationship, and it's a complex relationship in terms of treatment. Nothing that we've done research into specifically, but it is definitely something that we are working with substance misuse services to help offer support for.
Okay, thanks, Claire. That was great, very comprehensive answer. And then there's another question, Andrew, which you might be able to help with. There was a couple actually about the service. So the first one was about, you talked about that difficult first 12-week period and adherence during then. And the question really was about what the barriers were and what you can put in place to stop people dropping out during that crucial first 12 weeks.
Yeah, thanks for that one. I think in the first 12 weeks, a lot of patients that we see have never exercised, or they haven't done it in a number of years. So stepping foot into a gym, for example, a swimming pool, or even just a walking group can be quite daunting. And if they've got a lot of health issues going on, it may put them off slightly. So hopefully having that phone call and hopefully just to check in with them and sort of reiterate that the exercise plan that they've been given is tailored to them, and it's very safe and very appropriate. Another one could be changing circumstances, that as we can't offer all the exercise free and it's heavily discounted, things may have changed in the personal circumstances. So we'd look at other options of exercise, be that home exercise. As a team, we put together some long-term home exercise videos together. So one's for sort of diabetes, asthma, a circuit, for example. So hopefully we've got something for everyone. So if things change, we can maybe start off in a different direction and then maybe move up to what they'd originally chose, be that the gym or swimming or exercise classes, for example.
Thanks, Andrew. There was another question actually as well from Andy Freeman about whether there was mental health support as well put in place as part of the programme, as well as the physical activity side of it.
With ourselves, it'd just be sort of the exercise sort of side, physical activity side of ththings, but we do work very closely with the referrers, and if someone does mention something in a consultation that may need further support, we can liaise with the sort of GPs, nurses or referrers, as well as Living Well as a whole. There's quite a lot of sort of health and wellbeing support on the website if any of that tick any boxes for the patient, but mainly working with the referrers or sort of social prescribers and things like that, if it can be an onward referral or an onward flyer, if any of that information or support would be what the patient's looking for.
Okay, thanks, Andrew. And I think we've got time for one more just before we wrap up. So Claire, this is another question for you. From Daniela, who asks, how does your team incorporate reflective practices to ensure your service remains culturally competent?
Yeah, it's a great question. We continue a bit of a dual learning process with our BCSs, particularly sharing voices and inspired neighbourhoods. So we have quite a lot of meetings to really work on our materials to make sure that we're culturally sensitive and culturally appropriate. In terms of our staff, we ensure staff go on faith trails to make sure that they're aware of what's going on in Bradford. In terms of a faith perspective, we make sure that our staff attend culturally adapted training modules. We've partnered with Ishan, who's Islamic psychology provider in Bradford, to do training and to do reflective sessions to make sure that we are adapting our practice in a meaningful way. More recently, we've kind of started a co-production forum where we're working with people who've been through our service, and we're inviting them back into our service via the BDCT Involve pathway to really influence our structure, to influence our practice and our resources, and just to have that forum where we're actually learning from our service users, no matter what ethnicity, cultural background or faith background they're from, just to make sure that we're still working to what our community needs.
Great, thanks, Claire. Okay, I think we'll wrap it up there. Just a couple of things to say to finish. If you have a look in the chat, there is the link to the further session that we've got. We've got the last of our Learning Week sessions tomorrow at 1 p.m, which is called Leading with Evidence: What Works in Tackling Inequalities, where the Bradford Inequalities Research Unit, based up at BRI, are going to be feeding back as well on some of the work they've done around evaluation of RIC projects. So you can sign up. Sophie's put the Eventbrite link in there, so go to that if you want to, or share that. If it says it's full, fear not. You can just email us. There's plenty of room. So if you just email us at rick@bradford.nhs.uk, we'll make sure that you can get onto that session. And then there's a couple of other links as well to resources that Andy's put on there. There's all sorts of things in the chat. So the other thing is that we're going to send you all the final RIC report. We were hoping to have it for this week, that covers all 20 projects, but it's not quite back from the designers yet. So we'll send that, so you'll automatically get a copy of that if you're on this call. And then finally, just really thank you to our 4 wonderful speakers who all kept to time. We had such a divergence of community engagement techniques, through really serious mental health issues, through to physical activity, through to genetic awareness. So brilliant. Really thank you very much for that. And thank you all for attending, and hope to see some of you at our last session tomorrow as well. So have a great rest of the day and a great rest of the week, and see you all soon. Bye.